And so our first speaker for you this afternoon is Dr. Trevor Hart, who is an associate professor in the Department of Psychology at Ryerson University. The research that's conducted by Dr. Hart and his graduate students at the HIV Prevention Lab involves three related lines of scientific study: the identification of risk factors for unprotected intercourse among adolescent and adult populations at high risk for HIV contraction or transmission, especially gay and bisexual men. 2, examining the relation between physical health and psychological outcomes among people living with HIV. And finally, testing of behavioral interventions for people at high risk for HIV and people living with HIV that promote sexual health and life expectancy and reduce HIV and other sexual risk outcomes. Thank you.
That there.
All right, Dr. Trevor Hart.
Okay. So my talk is going to be a little bit more about the theory, but I will be unpacking it for you. It will not be something, my intent is to make it as accessible as possible and not to cover every last detail of each theory. I actually tried doing this talk where I actually covered all the details of the theory, and it took about an hour. So I've got about 20 minutes, so 25. So I'll be doing a little bit less than that. So in case you're an avid theoretician and you want to chat with me more about it, I'd actually be very glad to do so. But I want to make sure that this is accessible to people. So what I'm here to talk about is how syndemics do not come out of a vacuum and lessons learned from research. The first thing to do is to start out with a definition of That works. How about now? All right. Sorry about that. So the first thing is to talk about what are syndemics. So syndemic comes from two words, syn meaning working together, and demos in the people. So these are things that kind of work together in the people, but not working together like I like to work together. These bad problems that are working to kind of strengthen each other. It's defined as a set of closely intertwined and mutually enhancing health problems that significantly affect the overall health status of a population within the context of a perpetuating configuration of noxious social conditions. What does that mean in English, you might ask? What it means is that there's a bunch of problems that kind of strengthen each other. So problem 1 makes it harder to deal with problem 2. Problem 2 strengthens problem 3. Problem 3 might in turn strengthen problem 1. So they're all kind of, these problems are reinforcing each other, and they come out of a social context. Originally this was developed by Singer, who was studying the Puerto Rican community in Hartford, Connecticut. And there was a concern that originally, and still this is the case to some extent today, that a lot of problems are looked at in isolation from each other, and they don't actually take a look at how different problems that marginalized communities experience may actually be reinforcing or strengthening each other. Now, I've heard some critiques from some people before that are like, oh, syndemics, you know, it's just this public health theory, and it just talks about problems, and it doesn't talk about social context. It's like, if that's not true at all, actually. This comes out of sociology, and Singer actually specifically, most of the paper is about social context of these intertwining problems. She looked at migration, poverty, racism, and marginalization, all of which frankly can also be relevant for us as gay, bi, and other men who have sex with men. So the first epidemic to be described as a syndemic, or you can call this the SAVA syndemic, is the substance abuse, SAV is for violence and AIDS epidemic. And so she was talking about how substance abuse problems among Puerto Rican communities and the problem of violence related to poverty, marginalization, and gang violence and AIDS were all kind of mutually reinforcing. There are other types of syndemics. There's also, in developing countries, it's been described as a hookworm, malaria, and HIV/AIDS epidemic. In mental health, a malnutrition and depression syndemic. And sometimes it's been described as a mental health and HIV syndemic among gay men, but I don't really think it's specifically mental health. I think it's much broader than that. I think it's psychosocial problems broadly defined. And in the first study that was conducted by Stahl et al., I know it's a tradition in sociology that it's often the case just one person is an author and only you work on your own. In public health, they work in teams, and so there are actually a bunch of us on that. But Ron Stahl is the guy that really deserves the credit for kind of employing a syndemic model that had not previously been taken a look at among gay and bisexual men. And what he did is he looked at his study called the Gay Urban Men Study. It's with 2,881 gay and bisexual male participants. This was not necessarily an extra marginalized sample, just to kind of clarify. The guys were recruited from the gay villages in 4 different cities in the United States. And what he looked at is depression, childhood sexual abuse, partner violence, and multiple drug use. And so his goal was to show if there is a syndemic. So when we did this paper, our goal was to kind of show that these were associated with each other, and indeed for almost all cases each of these problems were associated with each other. For example, people who had experienced childhood sexual abuse were more likely to be depressed. People who had experienced partner violence were more likely to have used multiple drugs, and he wasn't necessarily viewing it from the lens of pathologizing people for using multiple drugs, but he was saying that each of these problems are associated with each other. Each of these problems were associated with each other, and as we'll talk more about, they were also associated with an increasing the chances of unprotected intercourse with a guy who is of opposite HIV status, so an HIV negative guy having sex with an HIV positive guy, but having unprotected anal sex, or having sex with an unknown HIV status partner, and to some extent, although a little bit less so, the higher the chances of being HIV positive. So if we take a look here for people that had 0 problems, and this is here, about 7% of them had unprotected sex with a partner of opposite or unknown HIV status, but it went up to about 23% for people that had 3 or more of these problems. You can see the findings are not quite as obvious for HIV positive versus HIV negative, but for people with 0 problems, only 12% of that sample was HIV positive, but for the guys that had 3 or more of those problems, it was actually, again, closer to 22-23%. Now, there's a variety of ways to look at these findings for HIV positive people. One of the things is that it is a possibility that they're overlapping findings because the things that put somebody, make somebody more likely to engage in unprotected sex as an HIV negative guy may also place them at risk for HIV. But I think another way to look at this is through the lens of HIV stigma, that a lot of HIV positive people, because of an added stress of HIV stigma, may also be more likely to experience multiple psychosocial health problems. And these findings have been found among other populations as well, among heterosexual women, among low-income marginalized women. Brian Mustansky did a great study with young men who have sex with men, I believe in Chicago. And these findings suggest that any interventions that are supposed to be reducing risks for people seroconverting to become HIV positive, or for HIV positive people to suffer from complications due to HIV, should include interventions to reduce psychological problems, which seem to be, in many cases, precursors to any kind of HIV risk behavior. A lot of the interventions in the past that were created were very HIV focused, but very narrowly HIV focused. So it'd be like, here's how you use a condom, do you need some education on how to use a condom, and let's talk about your attitudes about condoms, and let's talk about your knowledge about condoms. And by the way, that stuff is, I don't want to say it's not important, I just think that for a lot of gay men, we're actually quite knowledgeable about lots of that stuff. And we even know to, pinch the reservoir tip before we put it on, and to not put on backwards, and then to say, oh, no big deal, I'll just put it on the right way. I mean, I think a lot of us, even some of those finer tuned details, we're aware of those details. And so I think we need to go beyond that. I think the messages that were appropriate in the 90s may not necessarily be quite as appropriate now. And this is not to pathologize people that are having unprotected sex, but it is to say that it's not randomly found in the population as these data show us. Another thing I wanted to talk to you about is minority stress models. So minority stress models go a little bit beyond some of the syndemic models. It's not that Singer wasn't actually quite thorough. Singer was actually quite thorough, but Singer was looking at things through the lens of a sociologist, and so really educated those of us that didn't know as much about that, about some of the sociological conditions. However, there's also psychological conditions too, and conditions don't necessarily mean problems. But when I talk about things that are psychological, I'm talking about how we feel about ourselves, I'm talking about how we think about things, and I actually am also talking about behaviors. But it does go beyond behaviors. So I learned a new word from some of my colleagues in social science. I'd like to problematize the word behavioral scientist, because I think of myself as a behavioral scientist, but if you only look at behaviors, like, that's boring. Like, what explains behavior? What's going on here? And certainly I've learned a lot from my colleagues in social science who've really helped me to really broaden that lens out, so we're going way beyond the individual and talking about things like the social production of the syndemics. But these models that come from psychology, they do, I'd say, a decent job as psychologists in talking about some sort of social conditions and how they affect us as gay men. And you'll pardon me in case some of you do not identify as gay men. There's some people here where I'm guessing you might not be. But I'm going to just speak through the first person because it's easier for me. So what these models show us is that gay men and other men who have sex with men may experience greater amounts of stress, and therefore it can lead to psychological problems because they are objectively experiencing more stress. For heterosexual men, they experience stress too. And certainly if we think about minority stress models, there are many heterosexual men maybe from other minority communities. But if we think, for an example, somebody who is not a member of any minority community and is the kind of the stereotypical heterosexual man, he indeed has lots of stress that he can experience, that we can all experience. Stress related to family, stress related to relationships, stress related to finance, stress related to our employment. So these things can affect you, and also he may have certain kind of vulnerabilities. That's diathesis, another word for that is vulnerability. He may have just grown up in a certain environment that may have led to vulnerability to handling stress. Some of us, for example, in our families, we grew up with lots of privilege and lots of opportunities. Others of us did not. Some of us grew up in really supportive families where they really encouraged us. Others of us did not. So if we think about any vulnerabilities that can come from just who we were before we were an adult, where we didn't have as much control at all over our destinies, as adults we have a little bit more control, although of course that varies depending on your social position. But for gay men, they experience all the regular stressors, anything they did. They had a family, maybe good or bad, but they had a family, and on top of that had to deal with the effects of homophobia. And so that's what these models are really telling us. So they're certainly not models of pathologizing gay men. They're actually models that are kind of pointing the blame at the stigmatized minority status. That it's not being a minority, it's the stigmatization and the marginalization of the minority group. For example, the stereotypical 1%ers are a minority. This model is not really talking about them. Another thing that we can be thinking about that it does exist in these models is the theme of resilience. So resilience, although it's become very trendy, and I'm a part of that trend, I'm hoping to get some stuff on these kind of gay strengths and some of the studies that we're doing, and some of my teammates are here. Before it became more popular and we really started to catch up with what gay men were actually doing in their strengths, they were talking about this in these models, so that gay men do experience regular stressors and they do experience these stresses related to the effects of homophobia, but we also have our individual strengths, our talents, our creativities, our hope. And we also have the strengths of the gay community, which I think is often not very much assessed. The fact that we're all kind of here right after the CAR conference, I mean, I think that says something. right? So, and the fact that a lot of us are members of gay-specific or certainly gay-friendly organizations, like AIDS service organizations, I think that says something too. And so they actually do talk something about this. You can argue that these models can talk a lot more about our resilience, and they do focus more on the deficits, but that's really reflecting the literature. I think it's up to not just the theoreticians, but the theoreticians are telling us where to go, basically. We need to come up with, those of us that do the more empirical work where we just kind of study what's going on, but we don't necessarily make up theory. We really need to catch up with that literature. I don't think the theories are lacking in that regard that much. Another thing I wanted to talk to you about was about these minority stress models specifically, and some of its kind of daughter models. They talk about two different kinds of stressors, and one of them are distal stressors. And distal stressors doesn't necessarily mean in the sense of far away, but it means something that's kind of outside of yourself. So if somebody experiences violence, it's because somebody else performed a violent act on them. Or discrimination. Discrimination, in this case, we're not talking about a gay man discriminating against another gay man, but we're talking about discrimination that you experience as a minority member from somebody who is a member of a majority group. So these distal stressors can include things like objective discrimination, violence, but some things that are more subtle and maybe even more common, like harassment, or the microaggressions that we can experience, the day-to-day insults that we can experience as gay men just by being gay men. For example, waiting at a bus stop and hearing young people talk about "that's so gay." Did you see how he was acting? That was so gay. They're not saying the way we say it. You know, "oh, that shirt is really gay." When I say it, it's a compliment. But when that person, stereotypical university student or high school student is saying it, it's unfortunately not a compliment. And if you realize you are gay, and gay is kind of just a catch-all word for something that's terrible, then you can see how that can affect you. So but it could also be things like harassment. And harassment can occur in a variety of contexts, including in places that have legal protections. So I think although it's great to kind of talk about like our rights as citizens, that's a good place to be, and that's important that we have equal rights, but that's not sufficient. In fact, I originally came from the States, and I've actually never had people shout faggot more at me than in any city more than Toronto. So, including right at the gay ghetto, right next to the gay ghetto. I've lived in much more legally homophobic cities, but I was actually surprised at how many times people would shout faggot from a car as I was wearing totally normal clothes, normal gay boy clothes. I wasn't wearing a fabulous, you know, strapless gown or something like that. And by the way, people shouldn't be also shouted at for wearing a fabulous strapless gown. But I was actually a bit surprised, but I guess they figured it out, like we were kind of two men talking to each other. So these kind of distal stressors can really affect us, and these are kind of that's the homophobia itself. But the homophobia also leads to stress that we experience. It's almost like added levels of stress when you start to internalize negative messages about yourself. Whether that's kind of broad things that are relevant for all of us, which they call general stressors, like anybody can experience low or high self-esteem, but it's really only people who are gay or lesbian or bisexual or queer that can experience internalized homophobia, which is when we internalize negative messages about ourselves. And if you think that doesn't happen, then just talk to gay men about the gay men's community and hear them talk about, oh, well, you know, my friends are cool, but most gay men are blah, 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 negative, 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 and how a lot of us actually do feel that way, even those of us who are actually quite out and proud. It can really affect how we view other gay men, and you can see how that could affect us in relationships too. If you think that most gay men are not like you and they are bad and a low value. And in turn, these proximal stressors, so the stress of kind of the experience of homophobia within our own brains, is what is deemed to lead to health outcomes that are not good health outcomes. That at a level of stress leads to poor mental health, and I would add to that poor sexual health outcomes. And by sexual health, I'm not talking about whether somebody had sex without a condom or not. I'm actually talking about broadly disempowered sex, feeling bad about yourself as a sexual actor, not having the sex that you enjoy, only being able to enjoy sex when you're high, because sex when you're sober leads to all sorts of conflicts or problems for you. Problems with sexual functioning, those kinds of things. Sexual health is a lot broader than the way that it's sometimes assessed by public health folks. No offense to public health folks, I'm a public health folk too, but there's a lot of stuff that it's a little, we could do better than that. So this is the actual minority stress model. When I first did my version of the talk, I was actually going to tell you every single part of the model and explain it all to you, and then I realized that was taking 20 minutes. So what I think I'll do instead is walk you through the parts that kind of reflect what I just talked about. So people have an environment, regardless of whether they're a member of a minority group, but a minority status, and you'll notice here, I don't know if you can see it, but I'll say it out loud, it's not just about sexual orientation, but it could also be about race, ethnicity, gender, aboriginal status, class, other types of marginalization that people can experience. And so this can be relevant for lots of folks, including for the majority group called women that are not really minority. I call it majority stress model because of the effects of sexism. But in turn, these lead to those distal stressors. It's not that being gay makes people be homophobic, but because people are gay, in a homophobic society, they are more likely to experience the homophobia, in turn leading to these proximal stressors, and in turn leading to mental health outcomes. But you'll notice here that there is definitely discussion, not as much as there could be, on both coping and social support from the community, how we as a community cope, how we as a community fight against homophobia, or how we support each other through handling the effects of homophobia, but also individually too. Whether our social support networks are individual social support networks, or this kind of social support network. Another framework that adds to the minority stress model is the Psychological Mediation Framework, which again talks about these distal and more proximal stressors, but separates them out into general processes that everyone can experience, whether or not they're gay. For example, how do they cope? How do they handle problems? Do I socially isolate myself when I get stressed out, or do I reach out for support? How do I think about myself? Do I ruminate on things? When I get really upset, I just keep on thinking about the bad problems over and over again? Or do I try to find ways to kind of fight against that oppression that I experienced? But these can be also group specific. So whether you expect you're going to be rejected for being gay, whether you're concealing yourself, and if you think, wow, I don't do that anymore, I beg you to think about how you act differently if you are in a city that has a gay village versus if you weren't in the gay village. Because I know that me and my husband, we will literally be holding hands in certain places, and as soon as we cross Yonge Street, we'll stop holding hands. And I know we shouldn't, because we should be good role models for everybody else, but we're afraid of violence. And we also don't like getting shouted at. So these are things that happen even outside, very close to the outside of the gay village in Toronto, and I can imagine how it could be like when there is no gay village in the community where you might live. So, and in turn, these lead to these mental health outcomes. Whoops. So I wanted to talk to you about solving the problem too. We are, so it can be pretty depressing talking about kind of homophobia and its negative effects on us, but we're doing a lot of things to solve problems, and we should acknowledge what we're doing, and we should also acknowledge that these models can be used to help us to identify what would be some targets for change. Whether it's handling the distal stressors of the homophobia that we experience societally. I mentioned some things. I mean, this is not a exhaustive list. Anti-homophobia education and legislation legislation, for example. Leading to the proximal stressors, we can fight against those with pride and anti-homophobic messaging for gay men and other people in the LGBTQ2 communities. But also equitable health access. And these are things that we're all working on in Canada. For example, a lot of us fought for, making sure there's a Canadian human rights code that would say, it's not illegal to judge somebody and discriminate against somebody legally because of sexual orientation, and recently that was expanded to make it more explicitly the case for transgender and other trans individuals. And if this happens, what ends up happening, if we're actually successful at fighting the homophobia on the outside, it would remove a lot of this distal stressors as well as any effects on how we feel on the inside. The Planned Parenthood's TEACH program is another great example. They actually send youth into high schools to teach against homophobia so that you can start out earlier and you don't have to wait till you get to university to get any kind of anti-homophobia anything, which is what I had to do. My mind was blown by like the anti-racist, anti-sexist, anti-homophobic messaging. I was like, that makes a lot of sense. Why haven't I heard that before? Why'd I have to wait till I go to university, a position of privilege, in order to get that knowledge? Also, pride and anti-homophobic messaging for gay men. Gay straight alliances are common, and I'd probably add the CBRC's Totally Outright program to that. Helping people to kind of develop leadership and to take pride in themselves and in their communities and to see you can do something about it for yourself personally and also for others. It's a great example, and we're totally copying off of you in Toronto, so please come up with more programs for us. And for LGBTQ equitable health access, there are a lot of programs. I'm going to name some of them that I know a little bit about. Rainbow Health Ontario is a much broader program than anything I can come up with. It's amazing. They have, in each health district, they have people that are experts that you can call them up and find a gay or trans-friendly doctor. And they also do education of health providers so that they can actually do a better job at being sensitive and competent in working with LGBTQ people. So that's a good idea. Also, I'll put in a shameless plug for some of the stuff that we're doing. Gay Pause Sex is one of our programs. Gay Pause Sex is a program that's promoting sexual health among HIV-positive gay and bisexual men, and it's being administered by facilitators who are HIV-positive gay men. So it's a program of, by, and for gay HIV-positive men to promote positive sexual health outcomes, and it's being administered through Positive Living in Vancouver and at the AIDS Committee of Toronto in Toronto. And also programs that address mental health too and combine it with sexual health. We have one little program that we're testing out called the Sexual Confidence Program that addresses some of the extra anxiety that a lot of gay men experience about being judged by other people. And you can imagine when you have been judged by other people or when it's occurring potentially as we leave our, this comfortable, safe container that we have here in this room, you can see that there are chances for homophobia and for being judged negatively by other people, and that plays out in the gay community too, where there's lots of judgment that can happen as well. So this sexual confidence program reduces social anxiety, the use of alcohol and drugs, not for fun, but as a crutch when it's used as a crutch, because people don't feel like they can handle a social situation or a dating situation or a sex situation without the drugs or alcohol, to help people to feel more confident and comfortable so that when they're using for fun reasons and not for reasons that they might feel guilty about later on. So in summary, basically what we can see here is that these models do address some of the social context that we need to be paying attention to, but they go beyond behaviors into how we're feeling about ourselves, and beyond that into what's actually occurring, what are the types of marginalization that lead to these overlapping health problems that we can experience. And they also provide targets for how we can promote our resilience and bounce back against stress, bounce back against homophobia, bounce back against oppression, and establish positive spaces like this space here. Thank you.